Morning, everyone. It's 10:30, so we will go ahead and get started with today's all call. We do have a relatively light agenda today, so one quick reminder before we jump into that. If you do have questions, please make sure that you send those in the chat and send those to all panelists. And with that, I will turn it over to Emily Lubering. Actually, that's my bad. I do believe she's still connecting audio, so it may be just a second.
Thanks, Heike. I'm just joining a little bit late. I had a last-minute issue with my calendar invites. Thanks for forwarding that to me again. So I'm Emily Lubering. I'm the director of the Federal Programs Unit, and I have my Federal Programs Unit has the oversight for our waivers. So my updates are around the amendments that we are submitting to CMS for changes, and then the waiver renewal process and changes that we are submitting for July of 2023. Currently, FPU is working with the division on the addition of the Health Assessment and Coordination Service, adding that to the to our waivers. Right now, it's in the a flexibility under COVID, and then also with the current amendment that we are submitting, the rate increases will be included in that amendment. And that is right now with MoHealthNet and getting ready to submit it to CMS for approval. We also, you may have seen some emails go out or some blasts and seen that we are right now from June 1st to July 1st, we are holding our informal public comment period for our Mo Kids and Partnership for Hope waiver renewal. As I mentioned, that those will renew in July of 2023. So if you have a chance to join us on, we had one on June 7th, a webinar to review the proposed changes. And we have one coming up next week, Tuesday on the 21st. Last time the meeting was about, or the webinar was about 30 minutes to go over the changes that we're proposing on those waivers, and then also the amendments to align with, for CSW and COMP amendments to align with the renewal. What we do during that webinar is go over the proposed changes, explain the changes so that it allows for individuals, families, internal stakeholders, external stakeholders, our families, our providers, our TCM entities to provide feedback or questions to the changes now. And that helps us if we need to change wording for the changes so that they're clear in the waivers. Some of the changes that we are anticipating or proposing are moving remote supports from assistive technology, so remote supports will be a standalone service. We'll add virtual delivery for our 5 employment services, clarify the specialized medical equipment maximum limit of 10,000 per individual per year. There's some updates to the environmental accessibility adaptation home and vehicle modification service definition, updating personal assistant provider types, clarify shared living providers, those who can be a provider for shared living service, and then updating the shared living provider DSP requirements. And that update is really more of a clarification to make it match all the other requirements for our DSPs. And then just one other reminder about the COVID public health emergency. Right now, it's currently set to expire July 15th, 2022. And we usually don't hear until about a day or two before that expires if they're going to extend it another 60 days. So we'll be paying attention and seeing if that's going to get extended or if it's going to actually expire. And those flexibilities under the Appendix K, under the public health emergency, will expire 6 months from the expiration of the public health emergency. So that's all I have for updates. I'm going to check the chat to see if we have any questions. I'm not seeing anything. Heike or Kat, do you guys see anything coming to you?
No, nothing in the chat.
Okay. Well, everybody have a great Friday and a great weekend. I'm going to pass it over to Leslie to grow.
Good morning, everyone, and happy Juneteenth and happy Friday. I'm Leslie DeGroat, your division's clinical coordinator, and I'm glad to be able to share some information with you this morning. I'm going to just share my screen here, so give me a second. It's something that we have been working on. Hang on, I don't know. Oh, Heike, is it possible to pass me the little ball or arrow thing? I'm just not able to obtain it. Oh, awesome. Now I'm the presenter. Okay, I'm going to share. And I will share screen too. Okay, can everybody see my screen? It shows that it's sharing. So I'm pretty excited to share this with you all. Um, these are informational documents that we will be sending out in an email blast and be posting on our website. They're kind of what you might say hot off the press. These informational documents are on what is being called long COVID, or you also may have heard it be called long haul COVID. The medical terminology for it is post-acute sequelae SARS-CoV-2 infection, or capital PASC. It's kind of long, but anyway, these documents were created by Untitledability, our contractor who developed the health risk screening tool and who developed our Missouri-specific components to the HRSA process. Representatives of the Missouri Division of Developmental Disabilities also work with Untitledability to develop these documents. We believe it is important to bring awareness to this resulting phenomena of people having health issues long after the acute phase of COVID has occurred, so that in this regard, it can be recognized, evaluated, and then treated optimally. The document that I'm sharing on the screen can be for anyone, but also can be used to help educate direct support professionals, nurses, and even be shared with community health providers. It goes through symptoms and how the symptoms may look in a person with IDD. It also explains what is long haul COVID. And then it also, if you can kind of scroll down, you can see what each team member can do to support the individual. And then at the very end, it gives examples of when to seek immediate medical attention. And then it shows considerations for people with IDD. It's the lengthiest of the three. There's 3 informational sheets, and this is sort of the lengthiest one. It's got the kind of the most information, but it's things that you might be seeing in people. And then it also shows how that might be manifesting, because not everyone communicates with words, and a lot of people, you kind of need to know them to kind of see, changes and pick up on stuff like that. So it goes through that, and I apologize if I'm making anyone dizzy by scrolling. And again, we will be posting these and sending them out in an email blast. I just wanted to give you all a heads up. So here's where they have the interventions, and it goes through lists, and these aren't, you have to do it, but these are suggestions so that people can kind of know, what do I do? This is a new thing, so it's got quite a few different things to consider there, when to seek immediate medical attention, and it's not an all-inclusive list, but just some ideas. And then of course there at the end, considerations for people with IDD. Let's see, I'm going to go ahead and show you the second one. It's not quite as long. It's titled, let's see, Quick Reference Guide for Supporters of People with Intellectual and Developmental Disabilities. And then it just goes straight to the nitty gritty of the long haul COVID symptoms, and then like how they may look with a person with IDD. So it just kind of shortened it to get to the nitty gritty, as I said. And then we have another one that's it's just a 1-pager. and it's titled Long Haul COVID, Information for Families and People with IDD, and it has symptoms listed that could be long haul COVID symptoms, and then it recommends having a medical evaluation. These documents can be printed and shared with you or the person you support or their primary care provider at their appointment to help facilitate discussion, and then just open up the possibility that long haul COVID could be what the person is dealing with. As I said, these documents are going to be sent out in an email blast, then housed on our website. So please be looking for that email blast. And I just wanted to share a little bit more. Individuals with IDD are at a greater risk, for developing complications related to COVID. So we're just trying to kind of stay on top of it. I'd like to show you, hold on just a second, I'm going to pull something else up. I wanted to talk a little bit about COVID reporting because there was a change, as you all noted. And at the bottom of this page right here, this is the Department of Health and Senior Services electronic COVID-19 case reporting system. And at the bottom, you can see that there's a place where you can check for frequently asked questions. It's also got a reporting user guide to assist with any issues that, or just trying to learn how to do it. But if you'll click this purpley blue button that says MoDrop on it, that will take you to where you report. And let's see, I had it pulled up on a different screen. I'll go ahead and pull it up here. But that's what this looks like. So that is the new method for reporting. We are updating our COVID reporting guidance memo to have this new link to the DHSS MoDrop included in it rather than the previous one. And then another clarification that I was able to receive this past week, you do not have to report cases into MoDrop if the person was tested at a clinic, hospital, or lab, because they already have requirements to report these positives. We were getting questions from the field about if they've been tested elsewhere and aren't they supposed to report it, or are we doing double duty? And yes, that is the case. DHSS is requesting, though, that you report positives from your home testing. Another, just to let you know what's going on with Seymour EMT. All COVID cases will need to continue to be reported into Seymour EMT as you are currently doing. The rationale behind that is that we know that the BA4 and BA5 variants are growing in Missouri, and we know that people with IDD have a greater risk for serious outcomes. It's still critical that we continue to monitor and support people through this. Even though the rules in many places are more relaxed, we're just not out of the woods yet. Each strain, it seems like symptoms are changing. The newer strains seem to be making people tired, not hungry, not thirsty, and achy. And then in people who don't have any other health considerations or issues, it typically takes a few weeks to a month to get back into the swing of things. But now a person with other health issues or IDD, they may not recover as quickly or may have chronic problems after that. Dr. Stanislaus had used an analogy, and she said I could use it to illustrate what it does to a person. And then basically COVID infection drains out the person's immune battery, and then it opens it up to other infections. So it drains out that battery so your body just can't fight off other things. So after COVID recovery, people with IDD or other health indicators are at a higher risk for secondary infections. Post-COVID infection, it's still a month or so where the person could be still vulnerable to other infections. So please really monitor yourself and the people you support and make sure that you're getting sufficient food and fluid intake. And don't hesitate to reach out for medical assistance if you need to. These newer strains seem to really cut out the appetite and thirst, and this all has potential to have major impact on health and mortality for the people who we support. Just some data that I was wanting to kind of tell you about. So far in June, we're at 111 reported cases in the division, which is about where we were last July 2021. So in deaths from COVID last quarter, which is January through March of 2022, was 12, which is kind of maintained quarter to quarter. I just wanted to kind of throw that at you. And then this is something that you've probably heard about, and I just wanted to speak to it because it's coming up in the news and everything, but monkeypox symptoms, you may be hearing about that. or the prevalence of it, the Center for Disease Control is tracking multiple cases of monkeypox that have been reported in several countries that don't normally report monkeypox, including the United States. So per the CDC, monkeypox is rare and does not spread easily between people without close contact. The threat of monkeypox to the general US population does remain low, which is good. But that being said, it is still something that you may want to stay informed on. The illness begins with fever, headache, muscle aches, backache, swollen lymph nodes, chills, exhaustion, which those symptoms really kind of sound a lot like influenza, maybe some strains of COVID. But the differentiation here is that within 1 to 3 days, or sometimes longer, after the appearance of the fever, the patient develops a rash, often beginning on the face, then it spreads to other parts of the body. So they go through varying degrees of what's called macules, papules, vesicles, pustules, which are kind of pimples, boily looking things. Then they eventually scab and heal and fall off, and then the person's no longer, infected once that new tissue forms over where the scab comes off. The illness typically lasts for 2 to 4 weeks. And in Africa, monkeypox has been shown to cause death in as many as 1 in 10 persons who contract the disease. So just kind of stay alerted to what's happening in the United States related to this. I believe it was in, I want to say 10 states, but I haven't checked today. Let's see, monkeypox spreads when a person comes into contact with the virus from an infected animal, infected person, or materials that are swelled with drainage from the infected person's lesions or bodily fluids. And it can also be spread by respiratory secretions during prolonged face-to-face contact. So basically prevention, avoid contact with sick or dead animals that maybe you find out in the yard and you don't know their history. Avoid contact with any materials that have been in contact with an infected person or animal. Continue good hand washing measures and masking when in close proximity to people and you really don't know their health status. It's still a good idea. There's those basic precautions. Any signs of illness as described above, please report to your primary care provider, especially if you have developed the rash and or lesions as I described. So they can be evaluated and treated because there is treatment for it. Anyway, that is all I have prepared to speak about this morning. I'm not sure if there's any questions in the chat. I'll stop sharing my screen.
There's one in there, Leslie. The question was, what is the timeline that a provider has to report a COVID case?
Oh, I would have to look that up, but I'm thinking once they know about it, just like any other event reporting, I believe whenever an event occurs, you have like 24 hours or by the end of the business day to report it. So just kind of follow the general guidelines. I apologize, I don't have that pulled up in front of me. That was a good question though, but I would try to consider it just like you would any other reportable event. Just follow those same guidelines. And then if nothing further, I will turn it over to Wendy Witzig, Deputy Director of Community Operations. And I thank you for your time.
Good morning, everybody. And Leslie, thank you you did a perfect segue into, I wanted to remind people of the service that is out there, Station MD, that we are very excited and proud to be able to offer to our folks that are in the waiver. It is access to be able to talk with a physician that is specially trained in working with people with IDD. And it gives individuals, their families, and direct care staff who are working for providers immediate access to medical consultation and assessment so that they can talk with a doctor, determine if the symptoms that they're concerned about that are being exhibited by the individual need further evaluation or attention, or what to watch for, and if things progress, call back and then maybe go in. But it has been an incredible service to so many people. We have heard nothing but good things about it. I encourage everybody to consider that service. If you are a provider on the phone, please, or a support coordinator that's on this call, please talk with the families about it. If you're a family member, please ask your support coordinator for more information about it. I believe there's also information on our internet. So please look into the service. It is different, a different kind of service, as Emily was talking to earlier, which has given some folks some pause and created some confusion around it. So I wanted to speak to that as well. That it is not your standard fee for service. So you get a service and then you bill for it. This is a subscription type service. So the unit of service is 1 month. So you can request it at any time. Your support coordinator can do an addendum. If your annual plan meeting is coming up, you can request it and have it added during your annual plan meeting. Or if you haven't done either and someone in your care is feeling ill and you're concerned about it, you can go ahead and call them directly. You will get the service, and then we will authorize it and provide the billing access retroactively. And that also is very different from how our services typically work. And so understandably, we have had some support coordinators and agencies that were concerned about doing that and authorizing it that way and not getting sideways with MoHealthNet. So we do have guidance that is coming out. It may have been distributed yesterday, or it will be distributed today. So you'll have something in writing also that talks about how to authorize this service and answer any of those questions. But if you are a staff person or a provider or a support coordinator out there and you have questions about how to authorize the service or get it into a plan, please reach out to the division. And Heike, if you would put Holly Reef's email in there, you can talk with her, or just a member of your provider relations team at the regional office that you work with. Please consider the advantage that this gives to individuals who can be diverted from emergency room care if it's absolutely not needed. We know that it causes a great deal of stress on anybody when they go into the emergency room. I don't think anybody can get in and out of an emergency room under any circumstances probably in less than 4 or 5 hours. I know I've had quite a bit of experience with that, and that's always been my experience, and I just go in expecting that. And that's a lot of undue stress on the folks that we serve who don't necessarily understand everything that's going on. They don't feel good already. They're going through some extra testing and having blood draws and a lot of extra testing, perhaps because the doctor is not familiar with them or care for someone with IDD. And so it's a lot of extra poking and prodding and stress for an individual, that if you can have access to talk to a doctor and know if they need to be seen right away or if it's something that can be monitored, that is a huge service. If they do need to go in and be seen, that physician that you talked with Station MD will be calling the emergency room in advance and talking with the physician and telling them what's going on, what tests that they need to do. So it really reduces the amount of time that they spend waiting to get help, and also reduces the unnecessary testing that has to be done. So it's a great service to our taxpayers, because a whole year of Station MD is more than paid for by one diversion from an emergency room, and with what an emergency room visit costs. So it's an amazing service for individuals. It's a lot of peace of mind for families and providers who, might end up having to take multiple people into an emergency room with them if they've got someone who's not feeling good. You create access to other germs and exposures that people don't need to have. So please look at that service and give that some consideration for the people that we support. And one last thing that I wanted to just let people know about: if you are a TCM provider out there, the RFI for the privatization of support coordination went out yesterday. So if you have not seen it, please look for it. I think you go to probably Mobize to get access to that RFI. And just as reassurance to any of our internal staff who are on the phone, and as the why for all of you are wondering, why are we expanding and offering more privatized support coordination on a contracted TCM contract, we look for and expect a case manager to be carrying about 35 individuals on their caseload. It gives them opportunity and access to provide really good, high quality case management to individuals. And our state support coordinators, we are averaging anywhere from 50 to 100, and sometimes a little higher on caseloads. So we are expanding the privatization so that we can lower the caseloads for our state support coordinators down to the 35 or 40 per caseload level, and looking for help from our already privatized support coordination entities out there. So it will not be any loss of state jobs. It is just simply bringing case management, caseload levels down to a manageable level for our staff and our teams. So if you're interested in that as a TCM agency, please look for that. And you can also reach out to your CCM TAC or provider relations or your regional office director if you need access to that RFI. So I think that's all I have. If there's no questions in the chat, Heike.
Wendy, we have a couple questions. I apologize. I'm not sure if you touched on this or not. One of the questions was, we referred someone to Station MD recently, and they were told it needed to be set up with a support coordinator first. So I think the question is that accurate? What do they need to do?
No, it does not need to be set up with a support coordinator first. And I would ask that person to reach out to Holly or connect Holly with that individual so that she can help work through what happened there and who they actually talked to, so that we can clear up any confusion there.
Yeah, this is Emily. I also responded to that in the chat. I think what I've heard recently is that Station D has had some turnover for maybe those people answering the phone, and Holly's been working through with Station D with that to clarify so that we're back on this right page with that. With that, like Wendy said, individual can call Station MD upon needing a service.
Thanks, Emily.
And let me see, I think there was one other. Let's see. Oh, I think we have answered all of them, actually.
Well, I did see one. Is this a fully covered cost for folks currently on waivers? Is that, I guess, in reference to the Health Assessment and Coordination Service, Station MD?
I think so.
Can you repeat the question?
Yeah, sure. It says, is this a fully covered cost for folks currently on waivers?
I'm not sure I understand the question. It is a service that is available to everybody who is on our waivers.
And the subscription is covered by DD.
Yeah, it's covered by the waiver billing, and that covers the assessment and the coordination with emergency care if that's needed.
If there would be a need for the individual, if they were referred to the emergency room, that would be through state plan, through their medical benefits, or if they needed a medication that came from the service, that would run through their state plan medical benefits, their Medicaid benefits. I'm not sure if that's what I'm not sure if that's exactly what was meant by the question. I'm just adding that to clarify.
So there's just, I guess if that question came from a family member, between what the waiver covers and what the individual's Medicaid covers, everything would be covered and paid for any medical care that they were needing to get.
Okay, so there is another question from, there's several popping in here now. We were told that if a person wants to access Station MD, we have to complete a form and add it to the budget.
That is true, but it can be done after the visit has occurred. So if someone accesses the service when they're ill and it hasn't been added to their plan yet, then the regional office will be sending the support coordinators a list of individuals that they will need to go back and do an addendum on and add that to the plan, and then add that cost of that service ultimately to the budget. But it does not have to be done before the service is accessed. It can be paid retroactively. So when you get that name of someone who used the service, you need to just complete the addendum and submit it as you would through UR.
Also another one, does Station MD get paid $30 every month, even if the service isn't used? So if the individual doesn't use it for the whole year, Station MD would get paid $360, even though it wasn't utilized by the consumer for all months.
Yes, that is correct. It is a subscription service, so it gives you 24/7 access to physician assessment, consultation, and coordination, whether you use it or not. Some people might be thinking that that is not a good use of the dollars, but what I will tell you is anytime that someone goes to an emergency room, we are spending thousands of dollars, hundreds of dollars, thousands of dollars towards that care. And so it is for those who just divert one emergency room visit, it pays for the subscription several times over. And I also, want to just point out that I think it is the biggest and most proactive thing that the division has done in order to promote the health and wellness of the individuals we serve. So often when someone isn't feeling good, you have to weigh everything else that's going on, whether you're a family member or whether you're a staff person and you've got other people in the home. You might be the only one working. There's staff shortages. You might not be able to get somebody else to cover. And so you're trying to assess, is this something that's really critical that warrants me getting everybody out of bed or taking everybody into the emergency room and exposing them to all the germs and everything that is going on in the emergency room? Or is this something that's really not, that I don't have to worry about? This takes that worry out of that parent's mind and gives the parent and our staff out there peace of mind that they are providing the best possible health care to the people that they're supporting. They don't have to worry about having to make a judgment call. They let that clinical decision be made by a licensed physician. So for the $30 a month, that is a small price to pay for the peace of mind and the protection it provides to our folks with intellectual and developmental disabilities. And I'd like to add that if people want to have, if there's somebody out there that is wanting to have further discussion, you know, around that, I'm happy to have that discussion, because I really want people to understand what we're trying to accomplish, feel good about the service that they're offering and that they're providing, and to understand the reasons why we are really promoting this service. So please, if you're still not buying in yet, if you're unsure, you have doubts, please put an email or put something in the chat, send an email to the DD mail, and I will reach out to you personally and we can talk more about it.
Okay, Wendy, a couple of, oh, sorry, go ahead.
Well, I was going to answer this one. It says, is there anything specific that needs to be stated in the UR request justification for Station MD? I don't know off the top of my head, but I do know that I was part of putting together what Wendy mentioned earlier on the conversation about the health assessment and coordination Station MD service. There is a some information coming out about that process of how to add it, and it helps you. It will give you that information about the UR request and the justification.
Yes, and you'll be able to find that on the internet under governance, and then you're going to look under guidelines, division guidelines, and you'll find the procedure for completing the authorization or the addendum for the health assessment and coordination service. And there is a special form for this service for the addendum that will help you walk through everything that you need in order to get it through easily.
Wendy, I don't know, do we have a date when those documents are coming out?
If they aren't already posted, as soon as I get into the office, I'll check and see if we can't get it posted today.
Yeah, I think that would help with a lot of the questions we're getting. It has the process for adding it. You know, it has the different tracks. If an individual contacts the Station MD before it's on their plan, and then if it's added to the plan as you're doing your yearly or, you know, or sometime throughout the year, it kind of has the different tracks of how that works. And then there was also a really good document that came out last year when we started this service that gave a lot of background about it, which we might need to reference to Wendy to help give the full explanation of the service.
Yeah, and Heike, you are so much more familiar with where our stuff lives on the internet. If you could put something in the chat to direct people there, or if you want to jump on and tell people, that's fine too.
Let me see if I can find that link to as well.
One thing I will mention about the procedure that's coming out. With any procedure, it has an effective date. That's just because it's a newly written procedure on this service and but nothing has changed in terms of how we authorize it or that so don't let that effective date make you think that, oh, well, if they used it last month, that was before the effective date, so I can't do it. No, just means that this is when this procedure was written and we kind of published it and got it out there, but it is the current process. It's not a new process. It's the process that has been in place all along. So don't let that date throw you off. Just get the addendum in or amendment. We change our terms, so could be using an old term.
I just put in the chat the memo that came out about the health coordination service in August of last year. I think it was August. Let me check that. That is a larger, it was October actually. It's a larger document that will be pared down then to a smaller, more manageable document for the steps to follow for adding the service to the plan. And that's the one that Wendy was referring to as coming out, if it's not out already. But the one chat that I put in here gives you a lot of information. Someone had asked about information to share with their families or individuals. And it gives a bigger overview of the service, and then the new document will be a short and briefer document that will help with the process of adding the service. There was also a question of where these documents will be posted. I don't know that I know that.
The procedure, the guideline will be posted on the intranet. If you go to the intranet under the Division of Developmental Disabilities, scroll to the bottom of the page where it says governance and click on governance, you'll have a page open up that has ribbons with various types of regulatory requirements that are out there, CSRs, CFRs, and all that. At the bottom of that list, you'll see something that says guidelines. And if you click on that, that's where you will find this procedure.
That link's in the chat now.
Thank you, Pica. Any other questions coming up there in the chat? Just like I said, if you have reservations about the service or any questions, please reach out to me, reach out to Holly. We'll be glad to talk with you about it. Emily can talk to you about it. It has been an invaluable service. And as one of our services, you know, we are required to provide it as choice and give families and individuals the choice if they want that service or not. And so I need people to feel comfortable and confident in providing that choice to families too. So please reach out if you've got questions.
So Wendy, one question that popped in that we did miss was there was a request for a budget/rate increase update. Is that something that you want to touch on?
I don't have the information to really share about that, and Jess and Angie are both traveling now. That's why they're not on the call, unless Emily or Julie or somebody else on the call has information. And again, if you let us know we can reach out to you in the chat, whoever that was.
Okay, so you're breaking up a little bit.
Okay.
Now, Wendy, you broke up, but I think what you were saying is you don't have that information to share, and Angie and Jess are out of office, and I'm not on this call today. And I think you asked if I had any updates on that. I don't think I have anything that's concrete to share. That I know that we're working on them, and that information is definitely being worked on as far as those that are anticipated to be effective July 1 of 2022, but that hasn't been signed by the governor yet. July 1, 2022, yeah.
Okay, and with that, I think that gets us through all of the questions that we can answer today with the team that we have on the call. So we will be sending out an invite for the next all call, which will be in July. And if I was just really quick on it, I would tell you what that date is, and it will be July 15th. So you can go ahead and put that on your calendars. We'll send out an email blast about that. And this recording will be available on our previous webinar page for the division. So thank you, everyone, and we will talk to you again soon.